assignment that came through was an in principle change that was desired to teach repertory as a subject. Now, this is something that I don't know how many of you have experienced in your life when you were your UG students. But when I was a UG student and I did my MD also, in repertory, people typically asked me questions like whether this rubric exists over there, it is in which chapter, and whether how many remedies are there. So, all of this basically reflected on my memory and whether my memory was sharp enough or active enough to, memorize and retain all that I was being kind of taught. But this process in itself seeks us to change the way we want to engage with our students and engage with the subject of repertory. As the things would have it, they are expecting students to go to their OPDs from day one of their admissions. They are expecting that the student starts seeing patients. As it would be, the number of patients that are actually walking in and actually on paper, there is a dichotomy. But still, nevertheless, some patients do walk in. So it's not that there is a drought of patients to the colleges. And if we wish to look into repertory as a subject and look upon it to be reached to the student, then it can't be on testing his memory, because it is just next to impossible. Even if you ask me today how many remedies exist in BBCR or essential synthesis, I am dead sure I will be wrong by hundreds of remedies. To understand how to use the book when a patient has to be encountered, and whether we are able to influence in the student's mind that this book is of value, and this book of value is best used when you are actually seeing a patient. And then there are so many repertories. I'm sure UG has how many repertories as their requirements? PG has around 38 of them. UG may be having little less than that. Sorry? So around 2022. So there's not a great gap between the UG and the PG in terms of number of books that you have to look at. But the issue is of which book to use when, which book to use why, and which book to be used to what advantage. I am sure even in the undergraduate college, you may be having students who are in the final year, who are more conversant using their mobiles as a tool for checking out a repertory, and they have mastered that art so brilliantly that they can create a repertory sheet out of nowhere in a matter of moments, and the teacher is confused because of mobile ka screenshot, screen kitna bhi bada ho, 3.5 इंच के ऊपर नहीं जाता. रूब्रिक्स लाइन से लगे रहते, रेपर्टरी शीट उसके नीचे जाती है, तो स्क्रॉल करते जाते तो ऊपर का जाता है, नीचे का आता है. तो ऊपर जाओ नीचे जाओ, इस चक्कर में we are totally clueless of what we are actually seeing. I mean, that is my active experience, so I ensure that no child shows me the repertorization on a handheld device. But the world today works on that. So I have to learn the skill of viewing it, understanding it, and using it. So if I don't do any of these three activities, I am a redundant teacher. Because इस बूढ़े को कुछ समझता नहीं है. And that could be the norm. The world is changing much beyond that. The world is changing so rapidly, even in the field of repertory and softwares that are getting created. I am sure you may have experienced it in your personal lives also. कि all the computer-based repertories change the rubrics at a significantly high speed. They change the configuration of the remedies within that rubric also at a significantly high speed. They even change the gradation of the remedies within the configured remedies within the rubric also. So what was true yesterday is not true today. So what will happen tomorrow, we don't know. So artificial intelligence is walking in a big way. And this is happening, and this will go on, escalate. It will not come down. But this is something that will come up for tomorrow for the same student who will be taught how to use that repertory at the bedside for our patients who are seeing. There's a second issue in this that we have experienced. You know, when you are seeing a patient who complains that I have a headache on the right hand side which is throbbing, which is aggravated in sun, associated with nausea, aggravated by stress. Okay? As silly and simple as this example, you know, what is the first thought that comes to you as to what the patient is suffering from? Migraine. Okay, let's assume it's a simple migraine. Are there varieties of migraine? There are varieties of migraine. Now, if the student comes to you, there is a patient with this complaint, and if you are going to ask the student ki ja repertory mein bag kuta rubric milta ka, you know, what is it that we are telling the student to do? Any one of you, I'm sure most of you have done this. May not be the second years, but higher up the ladder. What does a student typically do? Yes? They hunt the rubric. Yeah. They go to the index. That's the easiest way out. पीछे से चालू करने का, आगे से नहीं चालू करने का. यानी ढूंढ, पर जब पीछे से चालू करेगा तो पहले क्या देखेगा? नहीं, पहले क्या देखेगा? अच्छा, पहले माइग्रेन देखेगा. माइग्रेन कहीं लिखा है क्या? बिकॉज मैडम ने बोल दिया माइग्रेन वाला पेशेंट है, देख लो. वो माइग्रेन तो रेपर्टरी में लिखी नहीं होगी, इंडेक्स में नहीं मिलेगा, बोरिक में मिलेगा. उसका थेरेपेटिक इंडेक्स में मिलेगा, तुमको वहां पे मिलेगा. रेपर्टरी के इंडेक्स में तुमको नहीं मिलेगा. अच्छा चलो, माइग्रेन नहीं मिला तो फिर क्या ढूंढेगा बच्चा? हेडेक. तो हेड ढूंढेगा मतलब वो क्या कर रहा है? एनाटॉमी में गया? नहीं, हेड में गया मतलब एनाटॉमी में गया. अभी चैप्टर ऑफ हेड. नाउ वी हैव काइंड ऑफ, the masters have classified those repertories in variety of ways. I don't know how many of you have set questions for you fourth final year people. Classification of repertory is one big favorite question of most of the teachers. And this classification business is a very complicated and a complex business. Because how many books you go and refer, there is a strong probability that classification rate variance with all those books that exist. So जो स्टूडेंट ने जो बुक पढ़ा, यानी जो बुक उसके किताबे में है वो पढ़ता है वो, और उसमें जो लिखा वो क्लासिफिकेशन उसके हिसाब से ब्रह्मवाक्य. जो अलग बुक में अलग कुछ लिखा होगा उसको कुछ उसको लेना देना नहीं है, बिकॉज मास्टर ने बोला नहीं, बोला भी होगा तो भी मेरे पास नहीं है. Now, given this situation and the master's way of creating repertory, which people say it's Hahnemannian schema, yeah, anatomical schema. You know, what do these words actually mean to us? And how do you kind of help the student to understand the relevance of the heading of that chapter and the significance of that heading vis-a-vis the subject that he is learning, and correlating that subject he is learning to the chapter of that repertory? And then you add a concept of aggravation, throbbing headache. You add what concept into the student's mind? When you add a throbbing headache, so head, you said it's kind of anatomy, you identified the anatomy, you add throbbing to it. What is the another factor that you are influencing into the student's mind? Patient तो ऐसे ही बोलेगा ना, सर फटा जाता है मेरा, साहब धूप में जाते तो बहुत सर दुखता है. पेशेंट तो बोलने को ये सिम्टम बोलता है, तुम बोलते हो जाके रूब्रिक ढूंढ. वो रूब्रिक ढूंढने निकलेगा तो पहले हेड का चैप्टर में जाएगा, तुम बोलेगा एनाटॉमी होगा. थ्रॉबिंग का क्या करोगे? It's a sensation, correct? So it's a sensation that comes up. Now this sensation arises due to what? Why does a person get a throbbing headache? What goes behind that? What happens in that physiology? That's understood, ma'am. What happens to this throbbing? Why should you get throbbing pain? It's a pathophysiology, so there is some change that occurs in the blood vessels. So when those blood vessels go on becoming more and more congested, the more and more sensation of throbbing evolves. So you add one more subject to the student's mind. You know, you go on getting into this process and you go on getting the student into subject of anatomy, get into concept of physiology, you get into concept of medicine, because now you are talking of simple migraine. Simple migraine is taught in anatomy. Simple migraine is not referred as a part in physiology. It will get referred when you come to medicine. Now, but a second year student doesn't jump into medicine. He gets introduced to medicine. But you are invariably asking students to go and see the patients from day one. So you necessarily start building the child's mind towards thinking. Now, this is one beautiful concept that struck me to the most. And if you can make students think on all these lateral aspects, you are ensuring that this child knows how to catch fish rather than you giving him fish. It becomes very easy for all of us. And that is something that attracted me. And that is something that gets reflected in all that is written in that overview. You know, I'm sure most of you may have seen that on the website, the second year subjects and repertory is also part of that. It is just a simple copy paste from that segment, nothing great about it. But what is important is, you know, we are asking students to learn the philosophy and application of basic core repertories. Now, this is the one of the first statement that is made, and then we are bringing in these three, which are the basic books that the student is expected to answer. There is one more statement, must not be taught in isolation. And there are another statements of horizontal integration with anatomy, physiology, pathology, surgery, gynecology, practice of medicine, and vertical integrated with Mater Medica, organon, and homeopathic philosophy in all the years. So you are not kind of helping the student to go top down, left to right. So as you start helping the student go top down and left to right, you know, you are making him understand that there is some sense in whatever efforts he is likely to make or he is being asked to make. And everything of this gets connected. You know, that actually gets into the important part of case taking. Virtually integrating all the subjects. You know, whenever you are asking students to sit in the OPD, either they are seeing the teacher taking a case or the teacher is asking them ki ja bhai iska dekh kya complaint hai. And when this is occurring, you know, as Munir sir was sharing, you know, shows and does, you know, this is the level at which you are directly exposing the student. It is not knows, which I did in my life when I was a student of BHMS, GCHI rather, and MD. It was all knows. Now we are asking people to show and do. Now this show and do business starts and ends with case taking, and he was describing at elaborate lengths the varieties of segments that get involved and get attracted when you look at case taking as a phenomena and development of, you know, affective, psychomotor, as well as cognitive skills of the person. You know, that is where the whole attraction starts. Now, this is one thing that we have to look up to. Continued exploration of these connections will generate new data, new repertories, and new applications and to new illnesses. You know, as you go on doing, I mean, how many of you also do PG teaching? I know him, so I know him for sure because I've been with him for last many years. Yeah, I know her also. And I know him also. Ma'am, I have not met you so far, but soon we should. Yeah, ma'am. Now, yeah, she is my teacher. So, what happens in all this? Most of the dissertations of repertory, have all the potential of creating new repertories. All of them. Based on the title on which you are working and you're making your student to operate. Do we make use of these newfound symptoms which we are creating in rubrics? Identifying the remedies that were there, because from the cases that you have taken, they get into the lowest bracket of clinically verified. They may not have gone into the higher brackets of clinically proved and reproved kind of stuff, but at least at the clinical verification you start. Do we collate this? Do we collate these rubrics and then make a publishing? You should. We should do it. And that is what we can start parking in the student's head when he is in the starting times of his life. There was an issue that also was brought to the notice कि साहब इतना पेशेंट तो होता नहीं है ओपीडी में अंदर, तो बच्चे को क्या क्या सिखाएंगे, कैसा सिखाएंगे, 100 बच्चा और 10 पेशेंट. अगर ये वेरिएंट, if there is 1:10 ratio in the OPD, then how do you ensure you go on to do it? And I just a very simple logic. You assume you have got 10 patients, you have got 100 students. Every year, if one student starts getting to expose at least 5 patients, in the whole year, 365 days, कम से कम 5 पेशेंट तो देखेगा एक बच्चा, कम से कम. उससे ज्यादा ही होगा. Let's go to the lowest denominator. And if 100 do it, then how many cases get established? 500? 500 cases for study of repertory every year, beginning day 1, end at day 5.5 years, is equal to more than 2,500 cases per batch. It's a huge amount of data. Huge. You don't have to talk of hundreds of cases per day. 5 in a year. That is good enough. I was telling people, even in my lifetime or my maybe grandchildren's lifetime, these 2,500 cases will never be completely consumed in terms of their learning potential. So this is something that actually attracted me into getting into all of this. Course outcomes is something that Munir sir was talking of, which we have specifically highlighted. We have to write, explain the need and utility of tool, need and utility, why you are using it. Describe the philosophical backgrounds, constructions, utility and limitation of these 4 repertories that are here. Able to describe various dimensions of case taking and demonstrate case taking in difficult, moderate and difficult cases. Now, this is kind of moving from 2nd, 3rd and 4th year. It doesn't don't look upon this as to be done at the 2nd year itself. Classify the symptoms, evaluate the symptoms according to importance and construct the totality of symptoms based on different philosophies. So at the end of when the child goes on to appear for the paper of repertory, you have to ensure you have traveled all this distance for the student. This goes on to look at more different processes, identify medium, method and process and techniques of repertorization. There is a definite way in which you conduct the process of identifying a symptom. For that you have to listen to what the patient has to say. For that you have to learn to ask a question that will help the patient to say something. So these are all skills. These are all basic competencies that we expect that the student will be able to discharge. Now, having said this, communication with the patients and relatives, develop ability to apply different case-taking skills. We are being asked by the commission to have peripheral OPDs, have IPD, have OPD. So the student is exposed to variety of environments. Each of these environments has its own advantages and issues to be handled. And each of those issues has to be handled by the student under the guidance of teacher, so that tomorrow when he goes out into the market, in whichever environment he goes, he is fairly equipped as to how he should handle a case in various situations. Search for appropriate rubrics in different repertories. It's a very interesting phenomena. I mean, all of you may have experienced this also in your life. If you ask a student to check one rubric and ask him to go and check it in 3 different repertories, I'm sure the student can't trace what he saw in the first. He can't trace it in the second. He can certainly not trace it in the third because he's still thinking from the first repertory's idea. उसके दिमाग से त्या डोक्यातनं आयडिया जातच नाही. त्या पहिल्या रेपर्टरीमध्येच गुंतलेला असतो. सेकंड रेपर्टरीमध्ये त्या पहिल्या रेपर्टरीमध्ये जे शिकलाय तेच शोधायचा प्रयत्न करतो, त्याला सापडत नाही. तिसऱ्या रेपर्टरीत जातो, त्याला तर 100% सापडत नाही. कारण प्रत्येक रेपर्टरीचा पर्पस आणि अँगल ऑफ डेमॉन्स्ट्रेशन इज डिफरंट. So therefore he has to learn to think as to where I should search what in which repertory. Now this is something that boils down to the last aspect of software-based repertories. Software-based repertories are going to go into a big time. I'm sure how many of you use softwares? Oh, many of you use software. Achha, how many of you use your software in which you do repertorization of your cases? Achha, how many of you repertorize those cases and keep them in the database? Who monitors that database? वो database का क्या होता है? आपने जो केस लिया, उसको repertorize किया, वो repertorize करके वो सॉफ्टवेयर में रख दिया, और रखने के बाद वो जो repertorization और जो केस का totality है, उसका जो symptom और उसका जो remedy है, वो किधर जाता है? क्या होता है उसका? What happens to that? कहाँ किधर किधर सेव करते हैं, किधर रहता है वो? अच्छा, वो कौन मैनेज करता है? हाँ, यस मैम. उसी अच्छा, okay, yeah, yes sir. Any other thought on this? Where, and who monitors that data? Where and sorry, क्लाउड वरती. अच्छा, पण तो क्लाउड कोणाच्या मालकीचा? सॉफ्टवेअरच्या मालकीचा. त्याच्यावरती तुमचा अधिकार काय? तुम्ही रिट्राईव्ह करू शकता. पेशंट पुढच्या आला की तुम्ही परत जाऊन तुमचं रेपर्टरायझेशन बघू शकता. तुमच्या मनाला समाधान की मला जे हवं होतं ते बघायला मिळालं. मागच्या वेळेला मी काय असं anytime, yeah, that's perfectly possible. But where does that data actually, who monitors that data? You saved, you have a PC, you have a login, you enter, you open the door, you search rubrics, create a repertorization, park it. That's data with you. बराबर है? Whether that data is usable for anyone else, yes? That's not a full case. So the data gets divulged? No, the data doesn't get divulged. The information gets divulged. But who uses it and who monitors that data? How does your software look at this? How does that software make use of that data and the findings that come up when you start looking at it, and whether that data's database management system goes on to activate itself in a little higher mode and identify कि ये rubric का ये दवाई ये rubric में नहीं था, मगर 50 लोगों ने ये दवाई दिया है और उसमें ये symptom था, तो वो अपने हिसाब में उसको कुछ करता है कि नहीं करता है? मालूम नहीं ना, मालूम नहीं है. Yes, yeah, yes, 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 yeah, they do it. Yeah, well, you're very, very right. So someone is monitoring it, and someone is making use of it, and someone is modifying your database, and someone is modifying your rubrics and repertories, and we are actually contributing to it. We are contributing to it. It's not bad. Let's not get into good and bad practice. We are contributing. That's what I'm saying. In your dissertations, if you have, you start publishing it, it becomes a good contribution. Now, these are things that are going to change in a very big way as the things start getting changed, because machine learning will become an active phenomena, because what you are doing, the machine is learning and the machine is recasting your repertories by using its own logic, the logic which you don't know. I am sure. हाँ? अपने को मालूम है वो रडार का लॉजिक क्या है? अपने को सिर्फ स्क्रीन दिखता है, वो स्क्रीन के पीछे के लॉजिक नहीं मालूम अपने को कि वो दवाई वहां पे कैसे जाके गिरी और उसका 3 मार्क उसने किस बेसिस के ऊपर दिया और कल 3 था आज 2 कैसे हो गया. Now these are things that happen, they will happen, and this is something we need to be oriented to, because tomorrow's children, I'm sure, I don't know how many of you have grandchildren, I have few, and they'll know how to use YouTube much better than me. They know how to use an iPhone far smartly than me, because they know all the ways of opening and shutting and ensuring that me and my wife don't talk to their parents, but only to them, so they know how to switch off the call. It's possible. If that kid at that younger age is capable, then imagine an adult learner who is coming to you. Where will he take us? You know, sorry. Okay, now these are some things that are there very much in your published papers. We have tried to bring down for each of the terms what can and need to be addressed. You know, most of it is now kind of got structured. The primary purpose, what do you think, what could be the logic behind creating this kind of phenomena? What do you think could be the logic in creating this kind of phenomena? Suppose you're coming to term 1, you know, this is this, term 2, this is it. What could be the logic that is tried to be hinted at? Right.
Maybe a horizontal integration with organon. That is why case taking is there in term 1, and both for acute and chronic case, this is the very basic thing. At that time, it will get this thing, and as in term 2, as they progress ahead, they can start correlating pathology or repertory with pathology. Repertory can be correlated with pathology. So that also may be the thinking which is there.
One way, one logical thought. What could be another logical thought to this idea of bringing it down like this? Because this was not done previously ever. तुझे याद है कभी ऐसा हमने देखा था? हमने आज तक जितने भी भाई वाले कभी ऐसा हमारे पास तो डेटा नहीं था. Yeah, ma'am, he just shared that. What could be another logic behind this kind of? Yeah, second year, of course.
Sir. Sir, generally, if we are talking about case taking, we have a fixed format in our mind that in case taking, only 3 subjects are necessary. So there is no need for other any subjects. Usually this is the, because अगर हम केंट का लेक्चर्स ऑन होम्योपैथिक मैट्रिमोनी का पढ़े, उसमें उन्होंने ट्रायंगल दिया है, उसमें वो होम्योपैथिक मैट्रिमोनी का ऑर्गेनोन ऑफ मेडिसिन एंड रिपर्टरी दिया है. But the correlationship of these clinical subjects, including pathology, how it is correlated, and in the pathology, there are so many, generally in the general pathology, you will find the terms like edema, you will find the terms like gangrene, hypertrophy and all these things. And if you correlate these terms, that means the student will learn these general pathological terms can be used as a rubrics, and they are being represented in the Borik's repertory or Kent's repertory. So they have a high value, especially in the pathological cases.
case taking 83 to 104, that also covers. So in both,
So to know the prejudices during case taking.
Yes, ma'am. बोलो बोलो बोलो. समझो समझो.
I think it's starting from a simple level and going to more complex.
Having said this and pushed into that paper, what is it being, what is getting ensured? What is getting ensured? No, sir, I think I will. The one is very simple. Across India, this is the process. This is what has to be done. This has to be done for that student of that stage, everywhere, everywhere. What happens is then there is no way out. इसने केस टेकिंग का डे वन में उसके स्टूडेंट को जयसिंहपुर में जो सिखाया और इसने पूना में जो सिखाया और इन्होंने और कहीं सिखाया वो अलग नहीं होगा. There will have to be a uniformity because otherwise you will not be able to assess students at a uniform level. At this level, ये competency student के पास है, हो सकती है वाला मैटर कम हो रहा है इसमें. और ये प्रोसेस में टीचर की जो क्रिएटिविटी है, ये एक अलग इशू लाया गया था हमारे सामने कि टीचर की क्रिएटिविटी मार डालोगे आप लोग. सबको सब घोड़े 12 टक्के, सब कतार में चलो ये पॉइंट से वो पॉइंट तक. अरे मगर वो पॉइंट से ये पॉइंट तक जाने के लिए अलग अलग मेथड से लोग जाते हैं. कोई कूद के जाएगा, कोई भाग के जाएगा, कोई क्रॉल करके जाएगा, कोई अलग मेथड से जाएगा, किसी कंधे पे बैठ के जाएगा. These are all creative ways that the teacher goes on doing it. So what he was teaching us, the ways and means of media and methods of teaching learning can vary. It can be pure creative thought that the teacher can build in his mind, park it to the student and get things delivered from it. So one of the factors that we were actually looking forward is ensuring there is a uniformity in this process. Okay, this is something that is there, very much there. Most of it we are kind of done, we have experienced in our life when we were students. And we are also trying to change this process in a little different way. This becomes one big thing that comes up. See, without case being the center of education, getting these integration business becomes a very big challenge. So therefore, because end of the day, the competency, like the Vice Chancellor sir was also saying and Tarkeshwar Jain ji was also sharing in the morning, end of the day, वो डॉक्टर पेशेंट को ठीक कर सकता है कि नहीं, उसके ऊपर तय होता है कि वो डॉक्टर है कि BHMS है. Now that is something that we are bringing about to very, very focused way. It has to be ability to treat patients, and your subject's value in the effort of treating patient has to be pushed into the child's active thinking. Okay, now this was a major issue that has come up. Interdepartmental integration. I think part 1, first year आप लोगों ने कर लिया है. आप रेपर्टरी वालों फर्स्ट ईयर में भी इन्वॉल्व थे? हाँ? आपका क्या अनुभव रहा है इस चक्कर में? इंटर डिपार्टमेंटल इंटीग्रेशन, कुछ एफर्ट हुआ इस विषय में या? हाँ? क्या किया? What was the process that you people adopted at your college?
एनाटॉमी के रूब्रिक्स बताए उनको, एनाटॉमी के रूब्रिक्स, फिजियोलॉजी रिलेटेड रूब्रिक्स, साइकोलॉजी रिलेटेड वेरियस टर्मिनोलॉजीज वी इंट्रोड्यूस देम. उससे उनको थोड़ा सा इंटरेक्टिव लगा, अच्छा लगा. It was like a game for उनको तो बहुत नया ही था. They were not knowing the name of all the drugs. Still they were interested in finding out, converting the symptoms. हाँ.
Okay. How did you do that?
For example, if physiology has completed the excretory system, and I went for that system, and I asked them to find out the rubrics accordingly for that system. And same with the anatomy. If upper limb is covered by the anatomy teachers, then I have done that. And second thing, we have even had the integration with the organon and this also, Materia Medica. For example, emotions is the topic. Then we had 3 subjects together, the seminars and all that.
So I teach at SPHM College, Srirampur. An interesting thing we did, I thought that sulfur is a big shot. It's like big antisoric. So literally from Materia Medica Pura, we have got 1,500 plus proving symptoms. And I had 85 children. So literally each one of them wrote 20 proving symptoms. Then Dr. Rekha ma'am teaches repertory to, so she told them some interesting rubrics of sulfur pertaining to mind. Then Dr. Darshani ma'am, she teaches surgery. So she came and told them the importance of sulfur in certain surgical conditions. And in between she talked about a few rubrics pertaining to, say, fistula and all that. So like typical, hey. Then Dr. Pansamar sir teaches physiology. So he talked to them about importance of sulfur in human physiology. And Munazza ma'am teaches gynecology. So she talked to the students about sulfur, and it's a few gynecological cases where sulfur was used as an intercurrent or the major remedy. So like, and even I thought that why not to call some Ayurvedacharya from nearby college to talk, because sulfur is used in Ayurvedic medicines. So, but I mean, nahi बोलू शकलो, but yes, we had like, की आयडिया आली होती की ओके आपण बोलूया आयुर्वेदाचार्यांना सल्फर विषयी बोलाल का प्लीज गंधका विषयी. सो ऑल दीज थिंग्स लिटरली ऑल द एक FMT सोडलं तर बाकी सगळे डिपार्टमेंट त्याच्यात इन्व्हॉल्व होते या सगळ्या ॲक्टिव्हिटीमध्ये.
एक्चुअली जो CBDC प्रोग्राम बनाया गया है, बनवला गेलेला आहे फर्स्ट इयरसाठी, ते फक्त एक टर्मिनॉलॉजीची डेफिनेशनची ओळख व्हावी स्टुडंटना, एवढंच त्याच्यामध्ये मेन ऑब्जेक्टिव्ह आहे. डिफाईन्ड रेपर्टरी, डिफाईन्ड रेपर्टरायझेशन, डिफाईन्ड सिम्पटम्स, हे ज्यावेळेला आम्ही टर्मिनॉलॉजी लेक्चर्समध्ये शिकवायला सुरू केलं तर त्यावेळेला त्याच्याबरोबर जे हॉरिझॉन्टली इंटिग्रेशन जे आहे ते ॲटोमॅटिकली येतच. मग स्टुडंट विचारतो हे रेपर्टरी म्हणजे नेमकं काय आहे, तर इट इज अ बाबा इंडेक्स ऑफ सिम्पटम्स ऑफ द मटेरिया मेडिका. सिम्पटम्स म्हणजे काय, मटेरिया मेडिका मीन्स व्हॉट, जस्ट दे आर लर्निंग डेफिनेशन्स इन द फर्स्ट इयर. तर मटेरिया मेडिकांची डेफिनेशन त्यांच्याकडून आम्ही मगअप करून घ्यायची, अंडरस्टँडिंग करून घ्यायची विथ द इंटिग्रेटेड टू फार्मसी सब्जेक्ट. आणि त्याच्यानंतर मग सिम्पटम्समध्ये वेगवेगळे आहेत. आता बाबा त्याच्यामध्ये हेडेक, पेशंटला आम्ही विचारलं की तो एक ड्रग पिक्चर तुम्हाला शिकवतोय मटेरिया मेडिकाचा टीचर, त्याच्यामध्ये हेडचे सिम्पटम्स सांगतो. मग हेड कुठून आला हे, इट इज अ फ्रॉम अनाटॉमिकल पार्ट ऑफ द बॉडी हेड. मग त्याच्यातले नोजचे सिम्पटम्स, हे नोज कुठून आले, तर इट इज अ पार्ट ऑफ अनाटॉमी. मग त्याच्यानंतर आले स्नीझिंग आलं, स्नीझिंगची पॅथॉलॉजी आम्ही त्यांना समजावून सांगू शकत नाही. त्याची पूर्ण कंजेशन आणि हे ते इन्फ्लमेशनचे 4 स्टेज, बट इट इज अ पार्ट ऑफ दॅट डिसीज. फक्त त्या डिसीजची त्यांना ओळख करून देतो. कंजेशन आहे त्यामुळे तिथं स्नीजिंग येतं, त्यामुळे ऑब्स्ट्रक्शन येतं, त्यामुळे डिस्चार्जेस होतात. अँड दीज आर द सिम्पटम्स which have been produced during the proving. Means the totally physiology has been changed during the proving. Those symptoms we are going to study in our homeopathic course. That has to be explained them. Means त्यांना introduction होतं वेगवेगळ्या दुसऱ्या सब्जेक्टचं. मटेरिया मेडिकामध्ये नेमकं फिजिओलॉजी नाही जास्त मिळणार, सगळे टोटली अल्टर्ड स्टेट ऑफचे पॅथॉलॉजिकल सिम्टम. मग ते पॅथॉलॉजी त्याला म्हणायची, त्याला पॅथॉलॉजिकल सिम्टम्स म्हणायचे, त्याला मटेरिया मेडिकामधले सिम्टम्स म्हणायचे. आणि त्याची जी इंडेक्स बनवलेली आहे टू फाइंड आउट इझिली सिमिलिमम इन द लास्ट इयर, तुम्ही फायनल इयरला ते करणार आहात, ते त्याची इंडेक्स म्हणजे आपली ही रेपर्टरी. सच इन सच अ वे वी आर ट्राइंग टू टीच देम द टर्मिनॉलॉजी इन द फर्स्ट इयर. त्याच्यामुळे त्यांना त्याचा पूर्ण एक बाकीच्या सब्जेक्टचा पण कमांड पण येतं. आणि दे विल केम टू हॅव सम कॉन्फिडन्स ऑन दिस मेडिकल सायन्स. हे बेसिकली फाउंडेशन कोर्सचा जो एक हे आहे त्याच्याप्रमाणे ते CBDCचा प्रोग्राम केलेला आहे. तो फोकस ठेवून आपण तसं जर केलं तर तसं दादा सेकंड इयरमध्ये आता तुम्ही ह्याच्या प्रिव्हियस स्लाईडमध्ये दाखवला सिम्पल केस टेकिंग. आता हे सिम्पल केस टेकिंग आणि अवघड केस टेकिंग काय आहे? आता सेकंड इयरच्या स्टुडंटला आपण काय शिकवू शकतो? सिम्पल केस टेकिंग, अक्यूट केस टेकिंग, क्रॉनिक केस टेकिंग. कारण आत्ता ते इन्फ्लमेशनची फर्स्ट स्टेज शिकणार आहेत अजून. तेव्हापासून आपण त्यांना कोरिलेट करायचं आहे की सिम्पल केस टेकिंग हानेमननी सुरुवातीला कसं सांगितलं, ॲज इट इज लिहून घ्या. पेशंट काय म्हणतो तसंच लिहून घ्या, तिथं तुम्ही डोकं चालवू नका. हां, डायग्नोसिस, डिफरन्शियल डायग्नोसिस, इन्व्हेस्टिगेशन हे आपण नंतर बघणार आहोत. ॲज इट इज ॲफॉरिझम नंबर ह्यामध्ये सांगितलं आहे की नोट डाऊन इट. तर ते नोट डाऊन करून घ्यायची त्यांना सवय लागावी. त्याला म्हणायचं आपण सिम्पल केस टेकिंग. मग त्याच्यामध्ये तो थोडं बहुत थर्ड मंथमध्ये, फोर्थ मंथमध्ये, 6 मंथमध्ये जसा जसा पॅथॉलॉजीचा सब्जेक्ट पुढं जातो तसं तसं आपण ते सिम्पल केस टेकिंगमधले सिम्टम्स त्यांना डिस्क्राईब करून सांगू शकतो. मग ते मॉडरेट केस टेकिंगमध्ये येतं आपलं. ते मॉडरेट केस टेकिंगमध्ये थोडे पॅथॉलॉजिकल टर्मिनॉलॉजीमधून त्यांना शिकवता येतं. एम आय राईट सर? तर हे मग त्याच्यानंतर मग मॉडरेट नंतर बाकीचं थर्ड स्टेज केस टेकिंग. तसंच अक्यूट, सिम्पल आणि क्रॉनिक. सो दॅट अगर ते आपण फोकस केलं तर हॉरिझॉन्टली इंटिग्रेशन पण ऑटोमॅटिकलीच होतं आणि व्हर्टिकली इंटिग्रेशन सुद्धा ऑटोमॅटिकली होतं. कारण त्या रेपर्टरीच्या टीचरला सगळं शिकवावं लागतं, सगळं समजावून सांगावं लागतं. पॅथॉलॉजीचे ऑल स्टेजेस, त्याच्यानंतर त्याचं डायग्नोसिस कसं करायचं, डिफरन्शियल डायग्नोसिस, त्याच्याबरोबर कम्पॅरेटिव्हली दुसरी कुठली पॅथॉलॉजिकल कंडिशन आहे की जिथं तुम्हाला स्नीझिंग होतं, ऑब्स्ट्रक्शन होतं किंवा थ्रॉबिंग हेडक होतं. त्या पद्धतीनं ते स्टेप बाय स्टेप आपण सिम्पलमधून ॲव्हरेज केस टेकिंगमधून गेलं तर आय थिंक दिस विल बी द बेटर वे इन द सेकंड अँड फर्स्ट इयर. थर्ड इयरला वी कॅन.
Any other thought on this idea of integration? You know, as teachers of repertory, you are trying to share. Any other thoughts? Yes, ma'am.
Hello, sir. Sir, I am from CMP, so we did a integration with the anatomy and the physiology, isn't it? So in the anatomy, there was a integration with the repertory in the chapter of the thorax. So with the students, we have asked them and shown them what is a rubric, means if the patient comes with the abscess in the axilla, so where they will see, like go in the chapter of chest, then go to the axilla and see the abscess. So what feedback I got from the students, right, because it was a very nice, they were so good to finding out the rubrics rather than the interns. And I got the feedback from my students and from my colleagues that from mathematics, anatomy and physiology, the students were telling me, ma'am, इससे अच्छा mathematics पढ़े ही नहीं, directly we are getting the remedies, that is either give Silesia or Hipazolf. So it was a very nice thing what I learned from them. Thank you.
So we can connect all the subject in in only single subject repertory, all the subjects. That is starting from anatomy till all other last year subject we can connect repertory. So
suddenly repertory has become Shahrukh Khan jala hai homeopathy.
वो राम के जैसे बन गया, राम की वैल्यू बढ़ गई ना, वैसे हो गया. तो sir, earlier it was not possible to focus in detail of whatever integration we have done. Earlier this subject was only for the 4th year, so there were very limitation practical to show all kind of these rubrics and subject wise. Now we can do this more better, and we can do it in according to them. That is first year anatomy repertory, second year subject repertory. So that will also easy for them to understand. And when they will come in the 4th year, then we can focus more on the computer related repertories. So the utility will be the 100%. I think so. And another challenge is for the teachers. That is, the teacher should know that is how we should taught this. Integration करना है तो हम भी पढ़े first year को कैसे करना है. Not only about only the chapters, that is how the Kent has given the index and what you have studied in anatomy, see your index. So that index and this index is almost same. N.M. Chowdhury ke volumes agar dekhe to, so this is also like that. So what we have, so we have also medicine for this, medicine for this. So the confidence of the student will increase from the first year itself, and it will become more interesting for them. So I feel so, and this we can go more detail as far as the rubrics are concerned and the subject wise, and this is not only learning for the students, but this is learning for the teachers also. So we will also improve. I think so.
You know, I think that CBDC template on the website has those tables, no, Gilbert, Bloom and all that stuff. You know, there's a last column of integration also. You know, what thought that was given to this is, you know, a teacher of repertory is attempting to correlate all the subjects that are relevant to that year for that student and make sense for him. Okay, one thought that if you have seen Munir sir's presentation in which he was talking of curriculum coordinating committee, you know, was one thought that he had shared. You know, one way that you could really look at, and he was also making a statement कि once upon a time वो subject में इतने घंटे थे, अभी वो घंटे काट दिए गए हैं, तो अभी उतना subject सिखाएंगे कैसा? You know, one of the ways of doing it was to bring about this integration. If a group of teachers who are teaching that come and sit together and identify who would focus what aspect of that. So that teacher of anatomy will not reflect on that. That teacher of physiology will not take care of that. You know, if you are able to check out your work in a manner so that मेरा काम कम होगा because कोई और लेगा, किसी का और मैं लूँ तो उसका काम कम होगा, तो progressively there will be an ease of work because you would have divided the work in a way in which that makes sense to all the teachers. And therefore, he was making a statement of people sitting there once in a month and coming about and checking कि जो plan किया था वो execute हुआ है कि नहीं हुआ है तो उसका क्या remedial action है. That is another concept of integration, of bringing down the effort of the teachers, because group of teachers doing the same thing makes no sense, one. Two, if you are engaging multiple people in doing the task, you are bringing down the number of working hours. So that could be an active eventuality in an effort to bring down the effort as well as time taken for that effort. So therefore the integration was having this idea as well at that time. You know, this is what we have listed down. 50 hours of teaching and 30 hours of non-teaching. Again, this has been broken down further into the number of hours. Now, this is something that we need to really look at. You know, ये जो areas हम cover कर रहे हैं, इसमें कौन से subject का कौन सा area मैं लूँ तो वो teacher को वो subject का वो area करने की ज़रूरत नहीं है. तो इतने ही घंटों में अगर मी जर एवढ्याच वेळात एवढं शिकू सांगू शकते तर तेवढा वेळ दुसऱ्या माणसाचा वाचला तर तो आणि काहीतरी शिकू शकेल जे मी शिकवणार नाहीये. आणि ह्या एक्सचेंज ऑफर मध्ये देयर कुड बी advantage of these 22 hours becoming more surplus or maybe fully utilized. They will not be kami. That is for thought that we had. Yeah. Yeah. Right. Right. Correct. Yeah, of course. No, what I am saying is, in how to use those 22 hours for these subjects or these areas is a full freedom that we have in our hand. When, yeah. हाँ तो you know the no now that's a serious issue. Now I am using the word serious is for a very simple reason. If you refer the organon ka same thing. If you refer, now if you are saying I am covering X component of organon, then go and check what the organon fellow is making a statement on this matter. Okay. Now that is where, let me complete. Let me complete. Of course we will say. Let me complete. That is where that curriculum coordination committee has to actually sit and function. Therefore I was asking whether as faculties have you experienced anything, because this was an area where people found it very difficult. A group of teachers having in that column that you have written or what is been written, a different subject also would have written something where repertory could have been referred. तो वो उसके सेगमेंट में जहां रेपर्टरी का रेफरेंस दे रहा है, वहां पे वो क्या इच्छित रखता है कि रेपर्टरी वाला करे, और आप जहां दूसरे सब्जेक्ट का रेफरेंस दे रहे हो तो आप क्या इच्छा रखते हो कि वो करे या उसके सब्जेक्ट का मैं करूं. ये जब आप एक दूसरे से बात नहीं करोगे ना, तब तक आपका ये सॉल्यूशन में नहीं होगा, कंफ्यूजन में रहेगा. That is the fundamental integration that is expected over a period of time. Yep. That's what he has proposed. That's what he proposed in the morning session, Curriculum Coordination Committee. And the principal heading it will... Arey, let's not all talk. Dr. Maisari, let's not all talk. One talks, all listen. Yeah.
If in the curriculum of organon, or rather the syllabus of organon, the same topics are there, and it's in the term 1, then it would be more easier. But if they have some different topics, then it's going to be a very challenging thing, because, like those 22 hours, but we have to take means these case taking, we have to start from case taking. Now organon, they may start from aphorisms, because in their term 1, aphorisms may be given. So, these kind of actual things are there in the colleges, and you have to, again, this secondary part is the maintaining of records.
Anyone wants to address to his thought, someone offering a solution to this. No, offer a solution.
Sir, one is a technical issue. No, but it's a technical issue. No, 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 sir. It's a fact of technical issue. Let me explain. Give it to her.
So, in our rough planner, we have decided that we will take the aphorisms related to do's and don'ts of the case taking, then related to hypochondriac patient, related to indolent patient, means which are required for the second year students level. Those only we are going to, no, means for regard.
If you go to the competency level, it's very clearly defined that if you start with case taking, you have to first define what is case taking.
So that we,
Classify the acute cases, then what are the
but but the, no more workshop.
That is precisely what we are attempting to convey. That's what I'm trying to convey. Is this is some exercise that all colleges will have to actually sit and do at their individual levels to try and figure out who will do what, because everyone, if they study every other subject section where my subject is referred, then I am better equipped to understand कि यहाँ पे उसकी इच्छा है कि हम कुछ करें, मगर वो हम क्या करना चाहिए जो आपके सब्जेक्ट में लिखा है वो कंप्लीट करने के बाद अगर वो तुमसे ज्यादा मांग रहा है, is a thought that has to be exchanged with due communication with each other, and that's a very, very fundamental interdepartmental integration that is desired. It has nothing to do with documentation efforts. It is in principle communication and arriving at a common understanding. See, आपण हा असा विषय आत्तापर्यंत कधी हातातच नाही घेतला. अबे घ्या, मी नाही घेणार. मी नाही घेणार. करेक्ट. नाही, आपल्याला रुब्रिक काढून द्यायचं असं कुठंच लिहिलेलं नाहीये. प्लीज अंडरस्टँड. नाही म्हण बराबर ये. You want to add something?
There are multiple levels of integration. Actually, there are 11 levels in which integration can happen. So the first level is what we call alignment, the temporal alignment. It means to say we create block periods where similar topics are taught by different teachers separately, not together. Like it can happen in first year if it is anatomy and physiology. You have the same system being taught in the same block period. You are not integrating anything. You are aligning the topics in the same block period so that the students get to know the different systems at the same time. This is the most basic. Now coming to what you are talking of, organon and repertory, one is that if suppose you have case taking which starts in second year, but the aphorisms do not start for case taking in the second year. So there is a mismatch. This is where you need to have some kind of innovation, because in any teaching, in any implementation of the curriculum, it's not that you have to integrate everything. There are areas where you need to set as the set induction, or there is also something where you have the previous knowledge, assessment of the previous knowledge, what we call as the entry behavior assessment. So when we discuss the entry behavior assessment as you plan the lesson, suppose you are planning the implementation of, say, something like case taking in repertory, and the aphorisms are not there in the second year. So you need to give the background information about the aphorisms related to case taking as a kind of sensitization, and then build from there. The depth of the learning will happen later in Organon, but whatever is relevant to understand repertory, case taking in the repertory, will have to be given as a basic sensitization. So everything you cannot have integration.
That is what I was trying to say, that we ourselves can integrate, like you said, sir, like if I'm starting with acute cases and aphorisms dealing with acute cases, and if those things are not there, then I myself would have to take, so that would also come under integration.
Actually, you don't say integration. You don't call it integration. It is like you align those. Because one thing is, this integration is a word which has been much abused. For everything we say integration. Let us not use that word. There are certain areas.
Because those...
because it is there in the syllabus.
From pathology are saying that there are 178 topics which have integration. So they are more worried than me actually. So
no, they need to relook. And we had that issue, they need to relook. Everything they cannot be integrating.
So therefore, yeah. See, we are talking of case taking, no? Yeah, here and now. I'll give one example. मैं आता जे headache चं उदाहरण दिलं ना मी, headache चं जे उदाहरण दिलं, मैं headache, aggravation, sun, throbbing. Let's talk of that simple symptom that a patient has. We are attempting to kind of look at horizontal integration. So you're looking at anatomy, physiology, and pathology components of the subjects that the student has just learned or is going to learn now. And when you are talking of headache, then if the student is able to recall what is the head and the anatomical features existing in the head, simple checklist, check with the student, he is oriented, he brings back anatomy of his head into his conscious action, thought and memory. Then he goes on to be reflecting on the throbbing concept, and we are talking of congestion, and then we are talking of physiology. Again, we are bringing the person to become consciously oriented to that what he learned just last year has relevance even this year. Okay? Then you are going into aggravation, son, which has nothing to do with anatomy, physiology, biochemistry or anything, but it is something to do with the patient as a person. Therefore, it carries the uniqueness of that symptom. Now, ह्याचा कुठंच सब्जेक्टशी रेलेव्हन्स नाही, पण त्या पेशंटच्या सिम्पटमचं ते रेलेव्हन्स तुम्हाला त्या रुब्रिकमध्ये मिळू शकतं. म्हणून रेपर्टरीमध्ये तुम्हाला हे रुब्रिक मिळेल, हे तुम्ही स्विच ओव्हर करता फ्रॉम एनाटॉमी फिजियोलॉजी टू रेपर्टरी ॲट दॅट लेवल. When you are talking of vertical integrations with materia medica and organon, you know, the logic applied over here is, suppose you are getting headache, throbbing, aggravation, sun, you go to a repertory, you see the rubric, you will see 100 remedies. समजा त्यातल्या 5 mark remedies 12 आहेत किंवा 6 आहेत किंवा 4 आहेत. मुलांनी त्या विषयाचा मटेरिया मेडिका, तर त्या मटेरिया मेडिकाचा तो रेमेडी त्या सेकंड इयरला आहे का नाही ह्याचा एक रेलेव्हन्स आला, म्हणजे तो आपल्याला आणायला लागतो ॲक्च्युली. तर त्या मुलाला तो मटेरिया मेडिका जेव्हा तो मास्तर शिकवेल तेव्हा त्याला त्याचा रेलेव्हन्स कळेल, आणि तेव्हा त्याला त्या सिम्पटमची व्हॅल्यू काय ही त्याला एस्टॅब्लिश होईल. तर मटेरिया मेडिकाकडे त्याचा बघण्याचा कल बदलत जाईल. Not just memorizing symptoms of a remedy, but making an effort to use them in treating patients. When you are looking at organon at that level, suppose तुम्ही पेशंटला थ्रॉबिंग हेडेकच्या पेशंटला बेलेडोना 200 दिलं, ओके, आणि पेशंटचं डोकं दुखायचं थांबलं, ओके, पेशंटचं डोकं दुखायचं थांबलं, ह्याचा रेफरन्स होमिओपॅथिक सब्जेक्ट्समध्ये कुठं दिलेला आहे? सो यू आर लायकली टू गेट ॲट सिम्पल अम्युलरेशन. You are going to Kent's observation, second yearच्या पोराला ते नसणार ते. पण त्या मुलाला होमिओपॅथीमध्ये ऑर्गॅनॉनमध्ये ॲम्युलोरेशन ही कन्सेप्ट आहे, आणि ॲम्युलोरेशन म्हणजे दुखणं बरं होणं आहे, आणि ह्याचं आपण जसे औषध देतो त्याचा परिणाम काय होतो हे आपल्याला शिकलं पाहिजे आणि ह्याच्याकडे आपण लक्ष दिलं पाहिजे. ही कन्सेप्ट आपण त्याला पास ऑन करतो. So you are trying to build the child's level of from information to maturity. You are not going to make that fellow competent physician on day one. So this is the way we are trying to look at these things. तर ह्याचा बेसलाईन असा आहे की तुम्ही त्या पोराला पहिल्या झटक्यात त्या सब्जेक्टचं ज्ञान प्राप्त व्हायला पाहिजे ह्या ओरिएंटेशनमध्ये जाऊच नका. त्या सब्जेक्टच्या रिलेटेड सिम्पटम असतो, म्हणजे बाईला ब्लिडिंग होतं, ओके, ब्लिडिंग कमी होतं जास्त होतं, त्याला नॉर्मल मेन्सेस म्हणतात का मेनोरेजिया म्हणतात का डिस्फंक्शनल युट्राईन ब्लिडिंग होतं, याचा आपला काही संबंध नाही. पण पेशंट जर तुमच्याकडे आला तर त्याचं क्लासिफिकेशन जेव्हा तो 4th गायनॅक ऑब्स्टेटिक जेव्हा असेल सब्जेक्ट तेव्हा तो ओरिएंट होईल. पण तुमच्या आजच्या घडीला जेव्हा त्या ओपीडीला तो पेशंट येतो तेव्हा त्या बाईला बाबा एवढे तरी विचार की नॉर्मल काय आणि ॲबनॉर्मल फ्लो काय, ह्याचं काहीतरी मापदंड आहे. तो मापदंड केस टेकिंगमध्ये पोरानं घेतला की नाही, ॲट दॅट लेवल यू कॅन स्टार्ट टू मूव्ह द चाइल्ड ॲट दॅट लेवल. हो, वाव वाव वाव. No, when we come to PG, we'll come to that also. No, let's get at that. We'll cross the bridge when we go to that end. नाही म्हणून नाही तेव्हा जेव्हा आपण पीजीला जाऊ तेव्हा पीजीला आपण हाताळू. येईल ना पीजीला काय शिकू ते पण येईल ना. We will go to that when we go there, no? So what we are trying to tell here is, see, as we were talking of previously, की त्या रेपर्टरीचा काय घ्यायचं विचार करायला लागला तर खूप काही काही घेऊ शकतो आपण. अच्छा. नाही पुस्तक उघडण्यापासून त्यांना सवय लावायला लागेल. ॲज सिम्पल ॲज दॅट की बोरिकची रेपर्टरी ही तुम्ही कशी उघडायची आणि कुठला चॅप्टर कधी येतो ॲज अ प्लॅन अँड कन्स्ट्रक्शन इन इटसेल्फ इज अ बिग चॅलेंज. यू कॅन स्टार्ट ॲट दॅट अँड यू विल रिअली एक्सपिरियन्स इन युअर लाईफ की लहान मुलांना ते बोरिकची रेपर्टरीचे चॅप्टर उघडून तो चॅप्टर तिथे आहे का नाही ह्याच्यावरती त्याच्याबरोबर तुम्ही एंगेज केलं तर तुमचे 1-2 सेशन कमी पडतील ते नुसत्या एका चॅप्टर आहे का नाही हे बघण्यात. 2 तास तुमचे कसे जातील समजतच नाही. यू कॅन प्ले विथ MCQs, you can play with quiz, and you can engage these people in just trying to trace which chapter in Borik's repertory exists and not exists, what is the sequence of it, why that sequence is there, what is the concept that Borik has applied. तो लिहितो ना, तो काय टाइप लिहितो, पेन लिहितो, कन्कॉमिटंट लिहितो, मोडॅलिटी लिहितो, तो सिक्वेन्स त्याचा आणि केंटच्या रेपर्टरीचा वेगळा आहे. अरे पण फायनल इयरला तुमच्याकडे कितीतरी रेपर्टरी शिकवायच्यात पोरांना, कितीतरी आहेत. म्हणून ती पहिली यादी ती घेतली मी, की तुम्हाला पोराला 4थ्या वर्षापर्यंत जाई तोपर्यंत किती रेपर्टरी शिकवायच्या आहेत. फक्त PG आणि UG मध्ये 12 का 15 रेपर्टरीचा डिफरन्स आहे. PG मध्ये तो कुठल्या डेप्थला त्या रेपर्टरी शिकेल हा विषय वेगळाच आहे, फार वेगळा आहे. पण आजच्या घडीला त्याला त्या रेपर्टरीचा वापर करण्याच्या लायकीचा, त्याला बसून शहाणं करायचं आहे का नाही, त्याला माहिती मिळाली पाहिजे की कुठली रेपर्टरी कुठल्या वेळेला का वापरली पाहिजे. मी प्लीज या ब्रिलियंट. माझं वाक्य चोरलं. नाही, ॲज आय जस्ट शेअर्ड विथ यू, की तुम्ही म्हणता ना की त्या मुलाला 10 तास 10 hours 1 lecture, 1 hour each into 10. So we are engaging a student for 10 hours on Borik's repertory. We are trying to figure out a way in which we can engage the child to help and understand that repertory. And I am very sure when you really want, I will come to your place and I will demonstrate that to you. But basically, I said for 2 hours, you run an MCQ on the Borik's repertory on these very silly things, and 2 hours we just fly. 1. 2. When you are saying softwares have these repertories already installed, ma'am, it is really worth the effort to try and study how those chapters in those softwares are created, whether it cracks the logic of how Borik's physical repertory stands. And we can really sit and discuss on these matters on repertory business, because the software doesn't help the child to develop the logic that the physical book can actually help him to develop. I am convinced about it. Because what the student does with these softwares, and we also do it, ते भिंगाचा सिम्बॉल असतो ना, त्या भिंगाच्या तिथे आपण टाईप करायला सुरू करतो, आणि मग त्याच्यानंतर धाडकन जे काही पडतं खालती त्याच्यातनं आपण शोधायला लागतो, अरे हे बरोबर आहे का, नाही हे बरोबर आहे का, हा हे बरोबर दिसतंय मला, मग जावा त्याच्या मागं. पण बोरिकची जेव्हा फिजिकल रेपर्टरी जेव्हा आपण वाचायला लागतो, तेव्हा त्याचा लॉजिकल फ्लो जो त्यांनी क्रिएट केला, ज्याच्यामुळे त्यांनी हे ह्या पद्धतीनं केलं. जर तुम्हाला okay, if I were you, and if I have to teach Borik's repertory, and if I am really keen on understanding why Borik created the repertory he created the way he created, then it is seriously worth an effort to go back and study what was Borik's professional life and what was his experience at that time. Now, UG student need not be exposed to that kind of threadbare delving into that subject of Borik. It's a big time thing. But it is important that teachers of repertory should park with the student this thought that there is a logic, and this is the logic on which he has created it, and this is the logic in which you have to refer this repertory. And this, I am sure, you'll be surprised when 10 hours fly. When 10 hours fly. I am very convinced about it. I am very convinced. Yes, ma'am.
what about the spiral of integration with third and fourth year student? What should we do in second year?
Since Repertory has started in the first year, you correlate whatever he has been taught in the first year head into the second year, because this is a very new subject which is never there. Now, instead of starting directly, say with the acute case, the topics which are given, what does para integration means is that you have to again just tell them about what repertory is, what they have learnt into the first year, which will be into the second year. That is what is spiral integration. That can be done, sir, and that is what actually we are starting with.
Comparative study of Kent, what I have learned, and now they learned it boring.
Yeah. Perfect.
I was just hearing, I'm not a, my subject is basically not repertory. But all the same, since Anita was talking about these things, Dr. Anita, there is one thing that we all have to think, that you all are thinking only from one perspective. Like you are looking at a student who is studying in Bhartiya Vidyapeeth, or maybe in D.Y. Patil, or maybe in some very good institute wherein you get quality students. But this is not the case pan-India. See, if you also might be experiencing this in our state also. If you go to some rural place, even as of today, students cannot speak good English, which is a medium of understanding and appearing for the examination. Using repertory is a far-off thing because it's something very new to them when they come for medical science. And when the student comes in the final year, previously as it was, when the repertory was there in the final year, I have seen even today that they are not able to convert the symptoms of the patient into repertory language. That is a skill by itself. Simple thing like if you ask a patient, or if you ask a student during examination, show me what is pre-eclampsia in Kent's repertory. He will just keep on browsing the whole repertory because he doesn't know how to use the repertory. Whereas if he uses a software, it is very simple for him to get it because that will answer every query of his. But you throw the repertory in front of him and tell him to search for it, it will be very difficult for him unless he has really done 10 cases of repertorization using Kent's repertory. I'm not a... जेवढं तुम्ही त्याचा सराव कराल तेवढं ते होईल आणि तेच तर आपल्याला फर्स्ट इयर पासून त्याला छोटा छोटा डोस द्यायचा आहे, मोठा नाही द्यायचा. जो पूर्वी आपण फायनल इयरला गेल्यावर डायरेक्ट द्यायचो. म्हणजे शी इज राईट इन हर प्लेस, ही इज राईट इन हिज प्लेस. डेफिनेटली इट इज यू हॅव कुठेतरी आपल्याला समन्वय गाठायचा आहे. आणि क्वालिटी ऑफ स्टुडंट्स, आता आपण म्हणतो की आपल्याकडे आता क्वालिटी ऑफ स्टुडंट्स येतात, पण माझं मत जरा थोडंसं वेगळं आहे. फॉरगेट माय ऑफिशियल कॅपॅसिटी. माझं मत असं आहे की वी आर गेटिंग स्टुडंट्स हु आर हॅव्हिंग 50 पर्सेंटाईल, बट वेदर दे आर डिझर्विंग ऑर नॉट इज अ व्हेरी बिग क्वेश्चन मार्क. बिकॉज ते कसं आहे माहिती आहे, पाठ करणं, तेच प्रश्न सोडवणं आणि ते मार्क मिळवणं हे एक वेगळी गोष्ट आहे. आणि तेवढी त्याची मेंटल अंडरस्टँडिंग आहे का, तेवढी त्याची IQ आहे का, हा एक वेगळा प्रश्न आहे. So we have to ponder on these things, and that is why when the commission thought of bringing up these changes, we were thinking pan-India. We cannot think of the 10%. 10% श्रीमंत लोकांचा विचार करून चालणार नाही, आपल्याला 90% गरिबाचा विचार करायला लागतो. तसाच हा प्रकार आहे. We have to think of all the students as a whole, not of those 10% who can, fare very nice even without coming to the classroom. So when you are teaching in the classroom as a teacher, you have to concentrate on the last bench rather than who is sitting on the first bench. Because first bencher, he is confident, he knows what he is going to do and what he wants to achieve. That is the basic difference. I am sorry I have interrupted you, but all the same, thanks a lot.
Thank you. Thank you, sir. Go ahead. Huh? Okay, we were where? Yeah, we were over here. Okay. असं म्हणतेस? बर. काय जेवढं कुणाला कधी किती खायला घालायचं ना ह्याचा आम्ही प्रयत्न केला की बाबा लोकांना तेवढ्या लेवलला आणून ठेवावं. Okay, try and work it out. You know, we have done most of this again with the primary concept of bringing in some uniformity across India of what students will learn at what time. I mean, these tables in elaborate details are talking of each of this, and we have even tried to address your 10 hours and Borik in this. Sometime, you see this. It's a big time thing. थोडक्यात महत्वाचं आहे, वाचून घेतलं ना तर कामच आहे. होईल ना, काही घाई नाही आपल्याला. ही इज टेलिंग मी मला सोमवारी सकाळी जाऊन स्टार्ट करायचंय. तो ही विल ऑब्वियसली स्टार्ट विथ व्हॉट ही इज करंटली कॅरिंग ॲट अँड वॉट एव्हर हॅज बीन हॅपनिंग अराउंड. Maybe around 3-4 months down the line, some thought, generates, and it could be a different way of he addressing to the same situation in the next batch that comes. Spiral integration. Okay. Anyway, going back and forth. Okay. Yeah.
This thing is, sir, this terminology like simple acute cases and simple chronic case has been defined. No, you have defined it, sir, but is it that in the third year and fourth year, like, will it be complex cases, or is it going to be that way? Because, sir, these concepts are little bit difficult to.
We were just trying to decode in an effort to understand how the teacher will interpret these terms. And one mechanism that we identified was attempting to define it. Okay, now progressively what happens as years go by, a simple case in the third or the fourth year can be something that is kind of difficult case for the second year. Because the level of maturity of the student as he goes up the ladder, what was considered as a difficult for a second year may be a simple for a fourth year. This is something, as the clinical experience of the child goes on changing with the engagement with patients, we start helping the child mature in an effort to understand patients and clinical conditions. You are going to make simple what was difficult here become simple there. So far no, because we have not gone ahead into third and fourth stuff, na? So far no, but grossly, yeah, this is what would be intended to at the end of it. Okay, now this is something that was, now this repertory is an internal thing, it doesn't get counted in the second year, but nevertheless, the formative assessment goes on as a part and parcel of our activities. We have tried to bring that on numerical values of that as well. I mean, this is pure technical situation. Yeah, this is what it is. Fine. I mean, that ends the whole story. And a new begins from tomorrow, Monday onwards. Any more questions? Not for you. Except for her, anyone has any questions?
These things, 1 month, 2 months, and this is, I think, August, September, October. No, we have to start, but we will have a small workshop only of the repertory teachers. Because, and, sir, ते येणारच ग, म्हणजे येणार ना. नाही कारण नाही आय एम जस्ट टेलिंग यू, कारण आम्हाला ना म्हणजे ॲक्च्युली फील्ड वर्क करताना किंवा कॉलेजमध्ये आम्ही शिकवत असताना बाकीच्या डिपार्टमेंट बरोबरचं जे कोऑर्डिनेशन आहे त्याला मग खूप प्रॉब्लेम येतो की वेदर त्या टीचरनी तो टॉपिक घेतला का, ॲनाटॉमीवाल्यांनी हा घेतला का, तो म्हणतो आता माझा नाही तो नंतर आहे, मग फिजिओलॉजीनी घेतलं का. सो देर आर मेनी, म्हणजे आम्हाला खूप डिफिकल्टीज येतात. तर हे कसे सॉल्व करायचे अँड व्हॉट आर आर इनपुट्स वेन द कॉलेज इज गोइंग टू प्रिपेअर देअर अकॅडमिक कॅलेंडर, किंवा त्यांचे जे एक्झाम्स असतात किंवा त्यांचा जो पहिला
पोर्शन ज्या टेस्टप्रमाणे आहे त्या टेस्टप्रमाणे आपण आपल्या रेपर्टरीचं पोर्शन घेणे. सो दॅट बिकॉज वी हॅव टू ॲडजस्ट विथ दीज सब्जेक्ट्स, दे विल नॉट ॲडजस्ट विथ अस. कारण आपल्याला
So when she conducts the workshop, we should bring that.
या कारण आता आम्ही PGला सुरू करतोय ना मेडिकल टेक्निक, सो विल डू दॅट. आणि आम्हाला ना ऑर्गॅनॉन डिपार्टमेंटबरोबर खूप प्रॉब्लेम येतो आम्हाला. सर आम्हाला म्हणजे रेपर्टरी टीचर, सर ऐका तुम्ही ऐका, नाही काय येतो मी तुम्हाला सांगते की म्हणजे ज्या नाही आय एम नॉट टॉकिंग एनी पर्टिक्युलर ऑर्गॅनॉन डिपार्टमेंट ऑफ एनी कॉलेज, आय एम जस्ट टॉकिंग अबाउट द ऑर्गॅनॉन सब्जेक्ट. तर त्यांचा आणि आमचा जो कॉमन पोर्शन आहे की म्हणजे मग केस टेकिंग असेल, डूज अँड म्हणजे जे काही असेल, तर त्यात म्हणजे इन व्हॉट वे दे आर टेलिंग स्टुडंट्स आणि आम्ही शिकवतो ह्याच्यामध्ये कधीच एकमत होत नाही. इट इज नॉट लाईक दॅट. आणि मग काय होतं सर, ऑर्गॅनॉन म्हणतं तेच खरं असतं कारण हां हॅनीमॅननी लिहिलंय म्हणून. तर सर खरंच यू सॉल्व दिस. आले का बघ सर, आले रियालिटी. आणि अजूनपर्यंत आमचं अनालिसिस इव्हॅल्युएशनवर एकमत झालेलं, मी रिटायर व्हायला आले, एकमत झालेलं नाहीये, ते कधीच होत नाही. आणि दॅट इज वी हॅव टू सी दिस प्रॉब्लेम. एक युनिफॉर्मिटी, एक स्टँडर्ड, त्याला काहीतरी आलं पाहिजे, हे असंच आहे आणि असंच शिकवा. सो दॅट इज फॉर बेनिफिट ऑफ द स्टुडंट. दिस इज व्हेरी सिरियस ॲक्च्युली. हे
subject, and that learning curve will create these kind of issues of territorial.
आणि बऱ्याच वेळेला काय होतं की म्हणजे माझ्यासारखी सिनियर थोडी म्हणजे मुरदाड बोलते, तरी आत्ताचे जे ज्युनियर लोक आले तर त्यांना म्हणजे दे कांट टॉक लाईक दिस. पण स्टुडंटचा लॉस होतो. दॅट आय वॉन्ट टू सजेस्ट. तर आय रिक्वेस्ट ऑन बिहाफ ऑफ ऑल, सो यू जस्ट कन्सिडर आर डिफिकल्टी. आणि मग एकतर हा जो पोर्शन आहे तो त्यांनी घ्यावा किंवा हा पोर्शनमध्ये आम्ही काय घ्यावं. सो इट हॅज टू बी क्लिअर. हो नाही, इट इज नॉट लाईक दॅट. आफ्टर ऑल दे आर टॉकिंग अबाउट इंटिग्रेशन. ते असं नाही करू देणार. आय एम जस्ट वेटिंग फॉर मंगेश. आले का बघ ना मंगेश सर. ओके सर इथे आले आणि सरांनी आपल्या सगळ्यांचं इतकं ऐकून घेतलं, आतलं दुःख सांगितलं तुम्हाला सर. हां म्हणजे ते कुठेतरी रिवाईज करताना म्हणजे सरांच्या लक्षात येईल. आणि अनुप सर इतके गोड आहेत की म्हणजे असं राग न करता त्याच्यावरती रेमेडी काढतील. नाही फायनल इयरला काय असणारच नाही आपल्याला. ओनली रिव्हिजन. हां घेऊया एक सर. एक मी मंगेशची वाट बघते. सरांना देऊया. मला दिल्यासारखं वाटेल. चलो we'll have a group photo.
I hope you might have enjoyed the food as well as the presentation for execution of this entire training program. A special mention to Dr. Mujib Ahmed, because all these people, those who have taught us, they are the mentors basically. They have prepared this syllabus. So what was their concept? See, one thing we all will accept, that homeopathy is undergoing the improvisation.